don't do half. Okay, now that he's standing, what you want him to do?
Okay. So can you please stand straight?
You want him to stand straight?
Stand straight. Your legs put closer together.
I can't.
Cannot. Okay. So I'll begin first with.
One of the knees.
Yeah, that's what I can do. So first we begin with inspecting from the front of the patient. You want to make sure.
This is not heavy, not yet.
So you make sure your toes are pointed forward. Cannot. Isn't serious?
Are you serious?
Oh, really?
Actually, there's something.
Sorry. So first you want to make sure you don't straight away go to the hip first. Always take a look at the shoulder to make sure that the height is equal. Okay. Then you can start looking at a closer inspection of the thighs and the lower limbs. So you can see first if there's any, obviously the groin should be exposed, any skin changes so far, any previous surgical scars that will help you with your diagnosis.
Scars not yet.
Okay.
When patient standing, you don't look at scars.
Okay.
You look at what?
Look at any muscle wasting of the quadriceps muscle.
That one also not when standing up.
Oh yeah, okay. The pelvic, the level of the pelvis, you see whether or not they're tilted. I mean, but now cannot see that. So.
Yeah, okay. So you look at the attitude of the patient, how they stand.
Okay.
You don't need to look very closely. Don't look for scars. Don't need to look for muscle or that. Not yet. Look at how they stand. So what do we mean by how they stand? Height of shoulders. If one shoulder is lower than the other, mean what?
Shortening.
Okay, maybe they have LLD. Some more?
Scoliosis.
Scoliosis also.
Huh?
Scoliosis.
Okay, maybe they have scoliosis. Some more?
Pelvic tilt.
No, shoulder. Oh, okay, pelvic tilt. Okay lah. Usually the shoulders is this is not the same height because of shortening or scoliosis. If it's shortening, then patient will have pelvic tilt. Okay, fair enough. Sama?
Subluxation of the joint.
How do you look for subluxation of the joint?
Yeah, I mean,
What else? Shoulder, okay, shoulder not level. Then you look at pelvic. Okay, pelvic also might not be level. Sama?
look at the lower limbs to see if they are internally, externally rotated.
Okay. Sama? If patient's limb length is not equal, but the shoulder is equal and their pelvis is equal, how do you think they will stand?
Tiptoe.
Tiptoe, okay. Let's simulate that. Anyone have a Anyone have something? Not good book.
What?
Not good book.
Sleep mode.
Ni tadi. Tanya doktor. Tak nak bijak ni. Dia mesti start from the
Cepat, take my own gate expose.
Dia compensate by size lower. Next one is
pelvic tilt.
Leg is hyperextended.
hyperextended. Okay, they can hyperextend. Or if they cannot hyperextend, they flex. So they stand like that. So this one master student also always get it wrong. They say, oh, this side got muscle wasting, this side no muscle wasting. But actually it's not. It's because it's flexing. So that's why the left side looks bigger. Okay. So if they're not flexing, one more they can. They stand like that. So that's the hints that you get when patient is standing. So you look from the shoulders, go down to the spine, look at the pelvis, and then you look at how patient is standing, whether it's symmetrical or not lah. If it's not symmetrical, you have to comment where is it not symmetrical. Okay. So that's what you look for when patient is standing. You don't need to look at muscle or that, not yet lah. Scar also all no need. Okay, then next.
Then next you should inspect from the side. Also, since don't have to look for any scars or muscle wasting yet, you can look for one thing is an inflection deformity of the hip or any hyperextension.
Yeah.
Okay. Then can I ask you to step forward, come on. Or you just turn around for everyone to see.
Okay.
Then you should inspect the back. Once again also, I would like to check for skin changes, etc. And also any deformities of the joint, such as the ankle and the foot.
Yeah, what's wrong with his ankle? No foot ankle lah, but yeah.
Flat foot. Flat foot.
Huh? Yeah, flat foot.
Asking you.
And it also has a. Okay lah, that one not important. Masters. Okay, next.
Then now I would like to check for his gait. So I'll ask him to listen. Face me. Do you walk? Or what? Turn around. Oh. So you're looking for the normal phases of gait. On the slide you can see that there's the stance and the swing phase. Do you walk it? I think there's a normal gate on the right hand side, but I can't pinpoint. Because it's a bit, how do you say?
Subtle.
It's a bit subtle. I don't know how to say it. You walk again. Slowly.
Right side.
Is it right side? His foot seems to be externally rotated. A lot on the right side.
Okay.
Kind of.
There's a reason why I got it.
Something went wrong. Please try again.
Okay, you say the foot progression angle lah is facing outwards. Right? Okay.
Yes.
That one is not so important for hips lah. Foot progression angle is more of the tibia and the foot. Towing is towing is maybe the hip lah.
Okay.
But what else you look for when patient walk?
Look at the shoulder and the pelvis.
Okay, so what's happening with the shoulder?
Swing.
What happened with the shoulder?
Contralateral arm swing.
Arm swing, no? If the patient has Trendelenburg, how do they walk with the shoulder?
The shoulder will sag
Sag.
downwards on the opposite side.
Sack.
You will tilt downwards.
No.
Drop.
Okay, so to make it easier for you to think, the shoulder either swings or drops. So swing is a consequence of what? Swinging is
Stability.
like windshield wiper like that. Drop is like a ball. Drop.
I'm confused.
So swing is swing is because the spine sways also. The spine sways because the hip, the pelvis is also swinging. So that's a target.
Trendelenburg gate.
Okay, the lumbar gate, the shoulder swings like a windshield wiper. If it drops,
Could be a short limb gate.
short limb gate. Okay. So yeah, I guess it's quite subtle lah. You will get it when you see enough. Yeah, you will decide what sort of gait patient has when you see enough lah. So shoulder either swings or drops. So Trendelenburg, it's a different pathology than a short limb gait lah. The patient might have equal limb length, but even though the limb length is equal, their shoulder still swing. That's a Trendelenburg. It can be mixed also. Okay, what other gaits do patients have?
They can also have the antalgic gate.
Okay, how do you define antalgic gait?
So for the antalgic gate, they will have a shortened stance phase.
Okay, short stance phase.
So usually when they walk like this, if my left side is antalgic, they will spend less time walking. So it's like this, and the swing phase will be longer. They'll put more force on the normal leg.
Yeah, okay. Some more?
Then they also have the high steppage gait.
Huh.
So high steppage gait is seen when you have common peroneal nerve injury. Then you have problems with your dorsiflexors, so you cannot dorsiflex.
Yeah.
So their leg is always like this. So in order to clear the ground, they will try to move it. They can either move it upwards, or they can move it. They can flex their knee and their hip, so they can lift it off the ground. So they walk like this. And normally there's a slapping sound.
No, that's wrong.
That's wrong.
Dorsiflexing.
Oh, dorsiflexing. Sorry.
You shouldn't be dorsiflexing. No, this one is different. Who drop? Show me who drop.
This.
Yeah.
Just put your feet down.
Just lift your feet and your knee.
Higher, higher. Higher.
You want to do it.
She wants to circumduction.
Circumduction is different. Circumduction is might not be good drop. Circumduction is weakness of hip flexors. Okay lah. There's other gates also, shuffling, all that. It's nothing to do with the hip, but hip more commonly is the Trendelenburg or short limb. Okay. Go again. What do you see with your shoulders?
The right side is lower.
Yeah. You see drop. Drop or swing? Go again.
So drop.
Drop.
Okay. Next.
Then next you move on to the Trendelenburg test. Alright. So you can do it. You can do it from the back. So you can ask you to face the projector. Okay. So you should be able to locate for the iliac crest. Is it okay if I start it?
No.
Don't have any pain, right? Alright. So you feel for the iliac crest. Alright. And then you ask him to lift up one leg. You bend your leg backward. Okay. And then you see whether you can put down. You see whether the level is it still the same. If it's abnormal, that means this will drop, and that will indicate a problem on the contralateral side. So there will be problems with the abductor muscles on the contralateral side, which are the gluteus medius and the minimus. And you repeat the same thing on this leg. You lift up. So you see whether this hand drops lah. So for him it's normal because they are going upwards. So the Trendelenburg test is negative.
So if move upwards means what?
The abductor muscle is working.
Okay, the abductor muscle is contracting.
Yeah.
So in athletes there is a few things they say why the abductor muscle cannot work. Can be pain, can be muscle, this one can be shortening. But anyway, you just decide whether the patient has positive Trendelenburg or not. There's also the modified positive. I think it is on the internet.
The one from the front.
No. That's fine. Not every patient will just let their pelvic drop. Right? Sometimes they will compensate by leaning on the other side. So when they lean on the other side, it seems like the pelvis doesn't drop, but you need to counter that leaning. So unless you can feel good contraction of the abductor, actually you can feel the abductor contract, then you can say it's positive. But if they lean, they're not actually contracting the abductor, they just trying to not make the pelvic drop. I guess not so important. But it is. So not all patients will have a drop lah. Then you can do the modified from the front. See whether that's very important for you guys or not. Okay lah, you can just demonstrate how they do the modified.
So for the modified Trendelenburg test, you can face the front now. Okay. So you ask them to repeat the same thing, but you hold their palm this time. Okay, so that's for balance lah.
Like that. Okay.
And can you lift up your right leg? So now he's not applying any pressure on this hand. If there's weakness of these abductors, that means this one was sat down, right? So in order for him to balance, he will push down my hand. He doesn't want to fall. So you try pushing this hand. So you're going to fall. Then it will be a positive test. Obviously, if there's the other leg, then it will be the same thing. So
This is the modified
you lift up your
modified
left.
Trendelenburg sign.
If it's positive, you'll press down here. So that is the modified from the front. Okay.
Try to counter the pelvis from dropping by using it properly. That's also the principle of how you reduce hip pain by using a walking stick. Right. Okay, next.
Okay, after that, you will ask the patient to lie down supine.
Okay, lie down. Okay, so lie down.
Okay, then first
So palpation lah.
Okay, now you do the inspection for the skin changes, the muscle wasting.
When patient lie down, then you look.
Now we can look more closely now.
You look at how he lie down. So now what is exaggerated?
Rotation.
the foot.
Yeah, it goes more ER.
Okay, yeah. And also you want to look for, after you see for the alignment, the rotation of the thigh and the leg, you can also check for any, now is where you see for any quadriceps muscle wasting. And if there's any skin changes, so there's a scar here. And you can also look for any surgical scars. You must look up here lah, but patient is not properly exposed.
Yeah. Now you should expose. When patient is laying down, we have another inspection. So you should
Expose.
should lift up lah. Look all the way.
You okay? Right? The patient has the right side lah.
No, not that. The hip. Why you look at the belly button?
Look at the groin region.
Huh? Groin ah? No. If patient have a scar, well, the scar most likely be. So sini turn and lift up all the way. Here you can see the buttocks. Not like that. That way. Okay. All the way.
All the way.
No, lift up lah all the way.
Okay. Lagi. Listen.
No need to lift up this. Lift up the pants. They expose. So the GP is most likely here, right?
Yeah.
You need to lift higher than that.
Okay.
Okay. Alright. There's no scars.
And also you repeat the same thing on the other side. Alright.
One also malu. Yeah, master student also always miss scars because they don't want to expose. Okay, then?
Then you palpate for the temperature of the hip joints using the dorsum of your hands. That's the feel for surrounding area only. Then you move on to feeling for all the prominences. So this is for any tenderness. You start at the pubic symphysis. You have any pain?
Nope.
Okay, no. If you have any pain, just let me know.
Yeah, sure.
Alright. Start from the pubic symphysis. You go along the inguinal ligament. Then the ASIS. Feel for the iliac crest. You ask the patient to turn a bit to the side. Only fully lah. You can feel for the posterior iliac, the DSIS, and also the greater trochanter lah just now. Then you repeat the same thing on the other side. Here. Okay. So after that, palpation is done. You want to go on to the Thomas test before you test for the range of movement. So for the Thomas test, you want to place your...
Okay, so here comes the... What's the word for it? The crossroads lah. So the crossroads is either you want to spend time looking for range of motion, or you want to spend time looking for
Comedy.
shortening. Okay, so all takes time. So the crossroad you decide which way to go when the patient is standing and after they walk. So if there's any signs of shortening, then obviously when you looking at the patient, you look for things which indicate that there is shortening. Or if you think that the limb length is equal, then you can go for the range of motion. So that's where you decide yourself which way to go, because everything will take time. But never mind, you can do the range of motion first. Okay, go.
Okay. So for the Thomas test, you want to place your left hand underneath the lumbar spine of the patient. Okay. So you want to feel for the lordosis, if there's any excessive lordosis. So for him, there's none. And then you want to flex the knee and the hip. So what you're trying to see is if the opposite hip raises. So, no worries.
What are you doing?
Looking for any fixed flexion deformity.
How to look for fixed flexion deformity?
When I lift up this hip and the knee, then the opposite hip and knee will
So you're looking
raise
from the
up.
top, is it?
Oh, on the side.
You have to look from the side. So how? How do you
Change side.
make it better? Change side? No.
Can we ask the patient to bend?
You ask the patient to bend lah.
Can you bend your...
Then ask them to, you hold lah. Ask them to hold lah.
Oh, ask them to hold. Okay.
Hold. Then you drop lower.
Lower.
You drop your head.
Oh, okay. There's no fixed flexion deformity.
No
So like
okay. You have to turn You cannot do like that. You turn. goes all the way.
Okay.
And you feel the lordosis. Lordosis is gone. So this no fixed flexion. You got hip flexion? Yeah, you got fixed flexion. What will it look like?
Sorry?
You
No.
got fixed flexion. What will the leg look like?
The leg will, like this,
Ah.
move up together also.
Not that much lah.
Not
Okay,
that
flex
much,
again.
Will you flex this? Will you bring your hip and knee? So I think this will come out a bit.
No fixed flexion, but it goes up like that. Means
Fixed flexion.
how much?
20.
Okay, 15 lah. That is the Thomas test. But if the knee cannot extend, this one will look like this because the knee cannot extend, right? So how do you neutralize this?
Patient to move towards the end.
Yes. Come now.
You move down a bit.
Come on. Okay. Do again.
Back. Okay. Use this. Place your hip.
Hold. So this one, the hip extension is not affected by the knee flexion. So even though the knee is fixed, flexion cannot, the hip can still go down. Okay. That's your Thomas test. Next.
Go back up. So after the Thomas test, you want to start assessing for the
Thomas test is for extension. After extension. After extension,
flexion.
flexion. Okay. How to do flexion?
So for this, you will test for the passive range of movement. So you want to flex both the hip and the knee. You see whether it's on the other leg and compare if there's any difference in the angles.
So after you do that, what you do?
Internal rotation, external rotation.
So how do you check internal and external rotation? You lift up again. No, right? So you flex first and then you bring to 90. Straight away check lah. Why you wasting time?
Oh. 20, 30 degrees.
Depends on gender lah. Female have more than male. 15 to 30. Yeah?
So 60.
60 to 90. You compare both sides.
Okay.
For him?
Internal rotation is a bit. About
How much is he?
15 degrees. I think.
Do again? Okay lah. Okay.
So it's
Then you compare. This one?
about the same.
Okay. Then?
That's more. Then you move on to abduction. So for abduction, you want to square the pelvis first. Okay. After squaring the pelvis, you want to hold the opposite ASIS, and then you want to abduct the leg to the side until you feel the pelvis move. Okay. Then you do this with adduction, but you should square the pelvis again. So this is about 40 degrees now.
No, you shouldn't square many times. When you square, then you feel for the pelvis shouldn't move. Sometimes
Okay.
the pelvis starts moving, then you have to square again lah.
Okay.
Okay?
Then you also hold this side for adduction and you cross over. It's about 20 degrees.
Okay.
Then you repeat the same thing on the other leg, holding the right ASIS.
Doesn't matter which ASIS you feel lah.
Okay.
Okay? So that's your range of motion. Finish.
Yeah.
So adduction is sort of related to limb length discrepancy. But we'll talk about that when we talk about LLD lah. Okay, then?
Then after range of movement, you want to look for any shortening of the limb length. So you do with, obviously you need to inspect first to see if there's any shortening. Right now I don't see any obvious shortening of the limbs. Then you want to do the Galeazzi test. Ask you to lift your hip up. You flexion to about 90 degrees. The foot must be touching each other, the medial malleolar line as well as the medial joint line. And you look from here to compare if there's any difference from the foot of the patient. This will indicate any shortening of the tibia. So there's no tree. Not really any shortening. And then you look from the head of the vision to see if there's any shortening from the femur. So far, no.
No.
Now this one's higher.
No, you don't look. You don't look from there. You look from here, perpendicular. You look here. So this is
Shorter.
no.
No.
Equal.
Equal. Okay.
You look from here. Here. What a bit.
Right side is a bit shorter.
Okay.
Then after that, you want to move on to the apparent limb length.
Okay.
So for the apparent limb length, you do not have to square the patient's hips. What you want to do is you want to locate the zippy sternum. Yeah. Yeah. Sorry. You want to locate the zippy sternum and you want to go all the way to the medial medullae of the tip of the medial medullae of the patient. It's about 112. And you do
How
this.
to make it look more professional? How to make it look like you've done this many times? Not like this, obviously.
Ask patient to hold.
No. Huh? Sorry?
Use the marker.
Ah, you mark. Because it always has to be a fixed point.
That's what I mean.
It's a pen lah. Mark the medial malleolus first.
Mark the tip of the medial medullae here.
Mark lah.
No pen. Oh, this ah.
See? Press your medial malleolus.
Tip.
There. So you need to show your examiner. Feel.
Okay.
Okay. It's either the start of the bone or the most prominent part of the bone.
Most prominent part.
So you don't get confused.
Okay.
So I usually feel the start lah. So
Okay.
here. Okay lah, not much different from yours. Maybe slightly higher. So you mark. Then feel first. So that way, you know every time you measure is the fixed point.
Okay.
Umbilicus or zippy sternum, maybe no need lah.
No, yeah. Okay.
Okay. So what other parts do you mark?
You also mark the medial joint line.
Huh?
Mark the medial
Joint line.
This is for the true limb length later.
How to feel for medial joint line?
Can I flex it
Joint line
first?
is a bit. No, you cannot flex because once you flex, it'll go.
Things here.
Yeah, so joint line is not so easy lah. Yes, yeah, he's thin, so can. Yeah, okay. But it's easier way is just to mark the top of the patella.
Top. Okay.
Yeah, you got. Okay. But yeah, okay lah, fine. You can do medial joint line. But medial joint line you can get it wrong lah, so just keep in mind.
Sorry, bro.
Okay.
Okay.
Then
Then you should use the, if you're using the true limb length, you should use the ASIS.
mark the size.
Here. It's here.
Okay lah, volunteer.
You can feel.
Cannot. You have to feel soft. Hard. Here. Where's yours? There.
Yeah, okay.
Soft.
Yeah.
Soft. No, lower down.
No logo.
Soft. Hard. Here.
Oh,
Here.
okay.
Ideally you bringing a marker pen lah.
Yeah.
Here. No. Why you mark like that? How to measure?
Yeah, mine can easy to rub.
No, here. Oh, okay, fine. Here. Okay. So now looks like you done it multiple times. Okay. Okay. Measure.
Okay.
Oh, true.
52.92.
Okay. You finish with your apparent, eh?
No. I mean, apparently it's here until here.
Measure lah first. So like I mentioned before, apparent limb length has something to do with abduction, adduction. How much?
116.
Can.
Also 116.
Okay. So if patient has a fixed abduction and fixed adduction, measure again.
One 117. 118.
Means what?
This is shorter. Shorter. But
Which limb is shorter?
the right limb is shorter.
Which limb is shorter? Ready? Which limb is shorter?
Left
So
limb
what
is
position is that? Huh? The adducted limb is shorter. So if patient have a fixed abduction or fixed adduction, that's where you can get apparent limb length discrepancy. So that's why it's important to decide whether the abduction and adduction goes to neutral or not. So if patient is lying like this, what does it mean?
The pelvis is not aligned.
Pelvis is not what?
Square.
Square. So there are certain conditions where you cannot actually square the pelvis, and you have to measure apparent limb length. Okay, but how do you measure true limb length if the pelvis cannot square? Minus. No. 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 You have to do a mirror image. So this is fixed in abduction. You measure true limb length by abducting also. Then you measure. If this is fixed in adduction, then you measure by deducting this also. Okay. Measure the truth. Marker hilang.
Ada. The sweat gone already. 51 and 91. $50.5. 90.5.
Betul ke? Okay. The right side was shorter. Measure again. Maybe the position not right.
$50 and 90.5. I think might be the pants also.
It depends.
Because I'm going up your pants.
Yeah.
Yeah, 50.5 and 91.
Yeah, okay.
Yeah.
There's a bit of shortening, I think. Okay, then after that,
After that, we should do the Bryan's triangle.
how to do Bryan's triangle?
So if the shortening is above knee, that means it's the shortening of the femur. Then you should find the ASIS. So that's not I marked it already here. Then you should draw a vertical line down to the bed. Then you should find the greater trochanter.
So you don't draw the line first, you find the greater trochanter first.
Okay.
How to find the greater trochanter?
Ask the patient to turn laterally.
Turn lateral lah. No, you need to do it supine.
Oh, supine.
Found it?
Think so.
Put lah. Your ASIS. Too high. Okay. That's your GT. So this is your line lah. Okay, good. Use this as your line. Okay, this is your perpendicular line. Okay. Okay. Never feel GT. Patient will know when you feel that his GT lah. That's your GT ah?
This one.
You need to feel from the back. Okay. This is your GT, right? You will know. If you don't know, you do this. Put your finger here.
Okay.
Patient will know. You tipu-tipu, patient will say that's not GT. Amak lah. Ayo. See, you penat-penat cari, then you leave it. For what?
Sorry doctor. Actually, how do we ask the patient if it is GT?
You ask lah, am I touching your bone?
Doctor, how much limb discrepancy until they will be affected by it?
Depends on patient lah. Some patients they don't like even 2 cm. Some patients are okay up until 4-5 cm. But yeah, usually say if it's more than 2 cm, you should equalize. No, you should give a shoe raise. Too high lah. You always start from lower. Tapi you can there. Yeah. You need one line. Doesn't need to be this one. Up also can. So that's the difference.
Yeah.
Your ASI.
Yes.
Oh yeah.
It has only compartment fixed.
After the Bryan's triangle, then that's it.
So you get a measurement 2 cm, then what? Finish already.
Compare on the other side.
Do lah the other side. You need to compare. You cannot say your Bryan's triangle is 2 cm and then just go off. You say there is a difference.
You recording live?
Live. Huh? No lah.
Live?
Not touching the bone.
No lah,
What's this Facebook live?
no lah, just video record
Am I
only.
touching the bone?
Look,
No.
go down. Go.
Yeah.
You want live is it?
Actually,
Insta live ah.
not really. So go down a bit. We'll start from below. Not sure. I don't think you got it. No. Can you try again?
Sorry, very lazy, very lousy. No.
Unit shifting.
You're pressing very lightly.
Oh, you need harder. Stand up.
其实是你 internal external rotation 的时候最高点的动作。
可以有一个。哇，好近。
Got 6 here.
Hmm?
Got 6.
There is 3, is it? Huh?
Oh, that I didn't count. That I didn't measure.
Measure 6 lah. 6 is banyak.
Banyak. I got here. The bone.
Where's your SIS?
Yes, I actually here.
Wait, 6 ah? No lah, doesn't look like 6 to me. Oh, okay lah, fine. 6 lah, maybe 4. Okay.
Sorry, I'm pounding you live. About the same round.
Six also. I need to pick up.
Okay, then.
And if there's any shortening here, means it's above the intertrochanteric line. If not, that means the shortening is at the shaft of the femur.
Okay. That's all. How you finish your examination?
I like to do a neurovascular examination of the lower limbs and also check one joint above and one joint below, so a knee exam and a spine exam.
Okay lah, that one no need to teach. Okay. Any questions?
So do you have to measure the Brian's triangle if there's no limb tuck?
You don't have to, but yeah, exam time I guess they want you to be thorough lah. So yeah, they won't penalize you for doing.
Extra.
But also depends on the time you have lah. That's why I said keep examination can take quite a while, but you have more time compared to the master student lah. So I guess if you practice enough, then your time management should be good. And if your time management is good, then you have time to do everything lah. But if you